Hello, welcome to Converging Dialogues. This is Xavier Bonilla. On this episode, I'm very excited to bring the conversation I had with Nancy McWilliams. Nancy is visiting professor at Rutgers University's Graduate School of Applied and Professional Psychology. She is a psychologist and trained psychoanalyst. She is affiliated with the Center for Psychotherapy and Psychoanalysis of New Jersey. She is a graduate of the National Psychological Association for Psychoanalysis. She's the former president of Division 39 of the American Psychological Association. She mostly specializes in psychoanalytic psychotherapy and supervision, and she is the author of numerous books, including the Psychodynamic Diagnostic Manual, Psychoanalytic Diagnosis, Psychoanalytic Case Formulation, and Psychoanalytic Psychotherapy. She is well revered within the field, and as I mentioned in the conversation, she's one of her books is the one I used in grad school myself. So it was a big honor, big privilege to talk to someone that's so well established and revered within the field. So in this conversation, we talk all about psychoanalysis, past and present, and the various iterations of what that looks like. So obviously we start with Freud and go all the way up until the present and what it looks like, and some of what the future holds for psychoanalytic thought or any type of psychodynamic case formulation. So we start by talking about the origins of psychoanalysis. We talk about Freud, the misconceptions of Freud. We talk about the evolution of psychoanalysis in terms of the theory, starting with drive theory, ego psychology, to object relations, to self-psychology, to relational therapy. We talk about what psychoanalytic therapists do well and what they could improve on. We spend a lot of time laying out case formulation or case conceptualization. So essentially, when a clinician has a client from a psychodynamic or psychoanalytic framework, why case conceptualization is super important. It's not just about skills and techniques and manuals and things like that. It's how are you conceptualizing the human being in front of you and trying to have a kind of a structure or frame of understanding all of the challenges and problems that they're presenting. So we talk about level of personality organization. We talk about defenses. We talk about countertransference and transference. We also talk about the training that's needed for students currently, whether it's in psychoanalysis formally or psychodynamic training. And we talk about what clients can look for with those that have any type of psychoanalytic background, and many, many other topics. I was so pleased with this conversation. I really was quite honored. I've been wanting to talk about psychoanalytic theory and thought and what that looks like and why it's important. As I mentioned in the conversation, there's nothing wrong with cognitive behavioral therapy or DBT or ACT or any of these kind of modern types of therapies that are used a lot. They all have their value and their merits. I'm obviously in my world have more of a preference towards psychoanalytic thought. It's what I use, and so I've been wanting to kind of give it its due and let people kind of hear about it and hear why it's still relevant. And couldn't really think of anybody better to do that than with Nancy. So as always, you can find this conversation along with all the other past and future conversations at Converging Dialogues at Substack.com. Also on YouTube, Converging Dialogues. So get over there, subscribe, follow, share widely, tell folks that might be interested. And now I bring you Nancy McWilliams. I'm here with Nancy McWilliams. Nancy, it's a big honor to have you come on my podcast. So thanks so much for doing this.
My pleasure.
Yeah, no, thanks. I was telling you right before we got on, you've written a lot of fantastic books. I have a first edition here of Psychoanalytic Diagnosis, Understanding Personality Structure in the Clinical Process. You've written many other books as well, Psychoanalytic Case Formulation, Psychoanalytic Psychotherapy, and many others. And this was This is one of the textbooks I used in grad school when I was getting my doctorate in psych. So it really is a big honor to have you come on here and tell us all about psychoanalytic work. Before we get into many of the topics for today, why don't you tell listeners, for people that don't know who you are, kind of what your professional background is in or clinical background, and what you're currently up to.
I'm a clinical psychologist. I actually got my doctorate in personality rather than clinical, but in New Jersey, you can get a license to practice if you have enough clinical experience. And that's the route I took when I was a graduate student. It was the heyday of the Johnson era community mental health center movement. And there was an effort to train a lot of people who had interests in nearby areas by the mental health center near me. I got my doctorate from Rutgers, and I got my psychoanalytic training from the National Psychological Association for Psychoanalysis, which was the first non-medical psychoanalytic institute, I think, at least. It certainly was the first one in New York. And I'm mostly a therapist, but I'm also a teacher. I like to teach. I like to write. And I was lucky enough to get my foot in the door taking over someone's course when he was on a sabbatical of some kind to teach at the Graduate School of Applied and Professional Psychology at Rutgers. And the students liked what I was teaching them. And the dean and the department chair, even though they weren't psychoanalytic, were very supportive of anything that the students told them that they were helped by. So I stayed there for 40 years on a 1 day a week kind of appointment, which put me around academics and students, and that was immensely good for me. Analysts often get too isolated and talk only to each other, as you doubtless know. So I'm still seeing patients. I have shifted my practice more toward consultation and supervision in recent years. I've always been in private practice. I love the work. Everybody's different. I love the individuality of everybody that I work with. I learn something from. Not just, like diagnostic differences, like whether you're more hysterical or obsessional or paranoid or whatever, but what's it like to be a twin? What's it like to be somebody who was born with some kind of facial defect? What is it like to come from India? What's it like to be brought up in a religious background that I'm not familiar with? All the ways in which people are all different fascinates me.
Yeah, no, I totally agree. I totally agree with you on that last point. I mean, really what you're saying is how do you see the different shades of humanity, in different aspects, and you learn something from clients in clinical work. I mean, at least I mean, sounds like you are, and I do as well every day. And there's something, it's like a bottomless well, it's just nothing. You don't get the bottom of it, which is special, I think, in some ways, and unique. And yeah, I mean, of course, academia has its place, and but yeah, there's something about doing clinical work. People have asked me before, would you ever want to just do academia, or maybe just just the podcast or something else? And then say, maybe one day I'll scale back kind of how much I see clients, but I really enjoy it, and I enjoy learning something new about folks all the time and what they teach me about humanity. And it's fascinating. Humans are
and you
absolutely
help people.
Yes.
You're useful. It's very special to have a profession where you get paid for being useful.
Yes, I would absolutely agree with that. And the change doesn't come in, sometimes people have this idea about therapy that there's these light bulb moments every session's like, it doesn't happen that way. It's a long process, but when you do have those moments, the payoff is great to see, not necessarily for myself, but to see that kind of transforming or kind of remaking of sorts for a client or patient is I don't know, it's a privilege in some ways to really be a part of that.
It is. It's a sacred trust.
Yeah, I would agree with that. Okay, so let's talk about psychoanalytic and psychodynamic work. We can talk about the distinctions there, but here's my kind of intro into this. So a lot of people will know different types of treatment, and they'll know different types of therapy. Many people will know cognitive behavioral therapy. It's a very common one. It's empirically supported. Derivatives of that are many. Another popular one that people like is dialectical therapy as well, DBT, which is done by Marshall Linehan, which has been around for a
Hmm.
couple of 30 years to 40 years now. So a lot of people don't know, I think, about psychodynamic therapy, both conceptually and in terms of treatment interventions. And so maybe just give us, I guess, a kind of overview of where this kind of comes from in terms, obviously this has origins in Freud, and it's a kind of, I guess you could say, sort of direct line from that. And there's different variants here, but and then kind of get us to where it's at kind of in a contemporary setting.
Yeah.
Many people think of Freud and it's very antiquated and dated, and sure, there's some qualms you can have about him or whatever, but I think people miss how psychodynamic work, or what it looks like in a contemporary 21st century setting. So if you could speak to that too, that'd be great as well.
Yeah, and before I start with that, I think I want to say it's partly our own fault as psychoanalytic therapists that people have not understood what we do. We aren't very good at doing the public relations part of our work, and we resisted for a long time, spending a lot of time doing research on it.
Mm,
And then there began to be a demand that there be an evidence base for what we do. And now there is. There's a
mhm,
huge evidence base for psychoanalytic therapies of
mhm,
various kinds. And there's an even bigger evidence base for the fact that the most critical thing in any psychotherapy is not the particular technique, it's issues of personality and issues of relationship, and personality in both therapist and patient. In other words, if you have a good fit,
mhm,
that makes a lot more difference than whether your therapist is doing exposure therapy or emotion focused therapy or any of the other particularly name brand therapies.
mhm,
So we've been our own worst enemies in the psychoanalytic community. We love to do what we do. We wouldn't want to bother proving things to the researchers.
mhm,
We trained people in freestanding institutes that didn't keep up a conversation with the university. So there are a lot of academics, especially,
mhm.
who equate psychoanalysis with a version of it that was even then a minority kind of psychotherapy in the 1950s, where you put the patient on the couch and the therapist says almost nothing, and eventually the therapist accuses them of having penis envy.
Mhm,
You
mhm,
know,
mhm. Yeah.
that kind of image
Mhm,
is everywhere.
mhm.
And Freud didn't practice that way. And there were some bad analysts who practiced that way.
Sure.
And some of them were quite arrogant.
Mm,
And all you need to do to turn off a whole community of thoughtful researchers is to act as if we don't need what you offer us. We
mhm,
already know everything.
mhm,
And that is partly the result of psychoanalysis having attained a certain medical prestige
mm.
in the 1950s. Um, Freud himself, I think if people actually read Freud, they'll find him fascinating.
Yeah, he's a terribly good writer. He's a
He's a
very good writer.
great writer. He was a good teacher. He changed his views over the course of his life, so he was willing to be wrong. He was wrong about a bunch of stuff,
Mhm,
and I think we made it a problem to have idealized Freud too much. And I don't mean just psychoanalysts, many of whom always, thought of him in a kind of balanced way. But there were people that thought that Freud was going to save them somehow, and everything reduced to psychoanalysis. And had you been analyzed enough,
mm,
and when you idealize something too much, eventually you're going to get the backlash.
yeah,
And eventually, people exposed the fact that Freud had known about some instances of sexual abuse
mm,
and hadn't said that in his reports. That doesn't surprise me because he was treating his friends and neighbors. he,
mhm,
he
mhm,
wasn't going to go about, violating all the family secrets. But also, it came out that he had gotten really fond of cocaine in the 1880s.
mhm,
I think if I tried to omit every psychotherapist who's ever flirted with a drug, it would eliminate an awful lot of people. But these days Freud is presented as this misogynist, cokehead weirdo.
Yeah.
Especially by people who've never read him.
Right.
And it's really not true. Especially as a woman, I have to say, I think he was wrong about things like the universality of penis envy. But I don't think he was entirely wrong about the fact that women feel envious of the power of men, and it's often symbolized in the idea of "I wish I had a penis." That seems like a no-brainer to me. And Freud was unusual for his time. The women he started treating, the people with so-called hysteria, conditions that we would now consider post-traumatic or dissociative conditions, he listened to them. This was at a time when everybody else was making fun of them, thinking that they were weak women. In fact, after World War I, when the soldiers came back and had the same kinds of symptoms, they were spat on because they were having weak, feminine kinds of problems. Well, Freud took them seriously. He listened. It was his patients who taught him how to let them free associate and listen for the themes. And that's a big part of even contemporary psychoanalytic therapy. He supported women on an equal basis with men in the field. He admitted Sabina Spielrein to his inner circle. He encouraged his daughter to become an analyst. Psychoanalysis is the only field I knew about as a young woman in which women were equally important as men as theorists. I mean, we had Karen Horney, we had Melanie Klein, we had Frieda Fromm-Reichmann, we had Anna Freud. And that you didn't find then in other fields. You find it now. But so I think he gets a bad rap. Not that I think he was flawless. I think one of his worst qualities was he tried to make psychoanalysis into a movement rather than, a conversation with other scientists. And he was sometimes he could get opinionated in ways that were not useful to the movement. And he tended to generalize. If he felt that something was true of him and a few patients, he tended to say it was true for everybody. And this is a big problem, the idea everybody has an Oedipal complex, everybody has this or that. If you read some of his stuff, some of his ideas were brilliant, and they're still out there, only we call them different names.
Exactly, yeah.
Researchers in the brain are really impressed with how much is unconscious, but they don't call it unconscious because that sounds psychoanalytic and like that weirdo Freud, and they call them implicit. Okay, there are a lot of things like that. There are a lot of psychoanalytic ideas that are just taken for granted in the culture, and because they seem reasonable, they're not considered psychoanalytic anymore. Like when people say they are going through an identity crisis, they don't know that comes right out of Erikson's book, and Erikson was considered himself a Freudian. Or when you say you're in denial or you're being defensive, that all comes from psychoanalysis. So it's a weird position now that analytic therapists are in, where our profession tends to be seen on the basis of all the things that are a little quirky about it, like Freud putting people on the couch, which is, on the face of it, a little bit odd. But not all the things that have come to be just part of cultural knowledge. So Freud did change his theories over time. And you asked me to talk about the evolution of psychoanalytic therapy. It started with Freud working with people with problems that were at the time called hysterical. And he learned that if you just let them talk and try to find the feelings behind what they were experiencing, their symptoms started to go away. So his first theories were a lot about the energy that goes into creating a symptom and how you have to dissipate that energy to get rid of a symptom. He was trying to, it's interesting, contemporary psychologists are always comparing ourselves to the real science, physics, And Freud did exactly the same thing. He took models from Helmholtz and Fechner and the physics of his day, so that he had concepts like cathexis, like, if I'm in love with you and I have something that you have touched, it has a special meaning for me. I cathect it. That's a physical idea, or the idea of sublimation, which in physics is, going from like a gas to a liquid. A frozen state to a gaseous state without going through a liquid state. Right. He talked about how people, will need to sublimate certain kinds of feelings. Like if you're feeling sadistic towards somebody, maybe you can turn that into doing something socially useful. Like maybe you become a surgeon and you cut people up for a living and it's all good, So sublimation, cathexis, ideas like that, there's still kind of that theory was kind of thrown out. That's all considered drive theory. You have certain drives. Your concern is, how are you going to get them met? You have oral drives. You have other kinds of biological states that you have to quell. That way of thinking about psychology is not central in psychoanalysis anymore, although there are people like Jaak Panksepp who have revised drive theory and have said Freud was wrong to say there were two kinds of drives, the life instincts and the death instincts. There are really 7 drive centers, and he can locate them in the brain, and he can talk about what neurotransmitters are involved and so forth. So drive theory has kind of had a resurgence, but it also never left some kind of popular imagination. You hear ordinary people saying, well, what did you do with your anger? Okay, that assumes you have a certain amount of energy in your anger and you have to put it somewhere. That's a concept that came directly from Freud. Okay? So that's drive theory. And then over time, and he was going in this direction too, but over time, drive theory and its cousin ego psychology, which was all about what defenses you use to handle your drives, moved into object relations. That had to do a lot with Melanie Klein's influence, and then Fairbairn and Guntrip, Winnicott, Bion. There's a whole British group that are called the British Object Relations Group. But I think Fairbairn put it best. It's not that the infant needs to satisfy drives. That's not the primary thing. The primary thing is the infant needs the safety of a relationship. And he began, I think there are personality differences that figure into people's theory. I think Freud was a highly secure person. And so he didn't immediately feel empathy with the need of so many of our patients to feel safe before they can even begin to feel interested in getting satisfactions for their drives. And Fairbairn said that the baby seeks a relationship, not a drive satisfaction. So, for example, I remember wondering when I first learned Freudian theory, why you wouldn't find more neurosis in cultures where there was a lot of famine. And there was no evidence that they had more neurosis than we do. But if Freud was right, and these babies weren't getting their oral needs met, you should have seen more neurosis. But you didn't. And it occurred to me back then, I didn't know I was an object relation theorist, but what matters to the baby is some sense that the mother wishes she could feed it. And if the baby feels that, they feel a kind of safety. And that's much more important than how much they get fed, is whether they feel they're safe with their mother and that she has their best interests in mind. So the reason we call it object relations comes from the original Freudian idea that every drive has a source, an aim, and an object. Like, eating, the source is in hunger, the aim is satiation, the object is food. Right. In the interpersonal drives, the object is usually a person. Right. Sometimes it can be a symbol, like to a patriot, the flag can be an object that has great meaning.
Mm-hmm.
But mostly we're talking about people, and it's kind of unfortunate that we use that clunky language. But the object relations movement began putting the emphasis on what's the person's story, what's the drama, what's the family they grew up in, what did they internalize, what did they learn about gender, about power, about safety, about the major human concerns, and how do they play that out again and again. So if you are grown up in a family where everybody betrays you and you've got two alcoholic parents and they neglect you, you're going to grow up thinking that the world is full of people who are going to betray you and break your heart and nobody's listening to you. So object relations theories ended up giving us much more clinical range. I was aware in myself of saying to patients when they were self-critical, for example, when they said, "Yeah, I'm such a wimp," instead of saying, "Well, you're using the defense of turning against the self," I would say, "Who's saying that in your head?" And you would find there was somebody they had internalized that was saying it. And then in the 50s and 60s, I would say ego psychology, which was still based in drive theory, and object relations theories were the two primary, rather competing ways of thinking about people, as exemplified in the so-called controversial discussions in Great Britain between Anna Freud, who was representing drive theory and ego psychology, and Melanie Klein, who was, the flagship person for object relations. And Otto Kernberg did a brilliant integration of those two ways of thinking. But Heinz Kohut here in Chicago, not here in Chicago, but in the United States, in Chicago, began feeling that the ego psychology and object relations movement didn't put enough emphasis on empathy and feeling with. He was extremely influenced by Carl Rogers. He doesn't cite him in his writings, but I know that to be the case. And a lot of what Kohut emphasized involved feeling with the patient, being attuned to the patient, not putting your theories on the patient, listening. And he helped us in another direction. You can be very right about somebody and completely unempathic, and you're going to be completely untherapeutic.
Can you explain with Kohut here about, he had a kind of, I guess you could say, maybe not a renaissance, but he wanted to pick up, I think, Freud's initial idea or conceptualization of how we understand narcissism, and understanding narcissism with a kind of, not a good, bad narcissism, but this idea of the self and how we will have different self objects and how we'll have all of these different aspects. Maybe how did Kohut kind of insert that kind of theoretical underpinning with the ones that were already there with ego and object relations?
Well, he normalized normal narcissism. I mean, Freud conceptualized narcissism as the cathexis of the self, and he felt people who were strongly organized around what we now call narcissistic dynamics were untreatable because they didn't have any energy left over to have the kinds of transferences in therapy that he had learned how to work with hysterical and obsessional and phobic and depressive patients. So Freud kind of wrote off narcissistic patients, but Kohut had a real feel for them. Kohut knew what it was like to be humiliated and to live in a state of shame. His son, whom I'm close to, tells me that he got his medical license from Nazi Vienna, and it said you're not allowed to practice. You graduated from the program, but you're not allowed to practice because you're a Jew. And then he has to go to the United States, where he knows no English, where he doesn't know the culture. And he had a real feel for people who have to build a self. under conditions of feeling like they're in a shame position. So he had a lot of empathy for people in who were trying to keep their self states steady, and he gave us a whole language for understanding how we all need that. When I'm giving a lecture, I find that I look into the audience for the 3 or 4 people that tend to nod when I say things. I'm using them as what Kohut would call a self-object. I'm basically saying, okay, I must be okay because I'm getting through. They're giving me the message that they get me. And we all use each other this way all the time. That's rather different from using people as to drive satisfaction objects, sexual objects or comforting objects and so forth. It's more about, I think I'm okay. And of course, in the kind of culture we live in now, it's hard to feel like you matter or you're okay.
Of course.
Things change so fast. The internet's out there. You can put a sex photo of yourself on the internet, or your boyfriend does, and you get slut shamed for the next 20 years. So there are all kinds of things that are hard on our self-esteem. And Kohut was a genius at being able to describe how people support their self-esteem and giving therapists a way to help this group of people that are increasingly large because of the particular challenges of contemporary life, helping them develop realistic self-esteem and reliable self-esteem. And then after him, there were the relational psychoanalysts who integrated all of this and made their emphasis was on the two-person nature of everything that happens in therapy. It's not like the expert therapist who's just watching the objectified patient, which some of the old literature sounds like it's like that. It's they're influencing me as I'm influencing them. We have a lot of right brain to right brain communications, the way we know now mothers and infants do. And we have to take into account our countertransference, not as how Freud framed it. When our patients have an effect on us emotionally, Freud basically said, well, you should have a benign physicianly attitude throughout the course of things. And if you don't, you should go back into your own treatment and get that fixed because basically you've got to be feeling generous toward everybody. But some patients make us feel bored or angry or irritated or attracted to them or any kind of a number of things. And the relational movement was part of a long tradition of saying that we've got to take that seriously as data. You don't act on it. To whatever extent you cannot. Inevitably, you do a little bit, and they call that an enactment, and then you sort of work out of it. But they really they talked about the we-ness of the psychotherapeutic dyad, not the knowledgeable expert who knows what they're doing to a patient. And I appreciate that. I think it goes back to Freud that he was learning from his patients. Psychotherapy, if you're an analytic person, is not about applying a technique to a DSM category. It's about developing a relationship in which the patient is increasingly able to talk about the most shameful, difficult parts of their life and bearing witness and helping them grieve. And, symptoms, in my own experience, dissipate just as fast as they do with the more targeted therapies. But people like to stay in longer because they're making really much more important changes in how safe they feel, in their attachment styles, and what defenses they use, in what emotions they're comfortable with and how they regulate them, in their self-esteem, in their sense of vitality, and in accepting what can't be changed and grieving and moving on. So analytic therapy can be short-term, but it tends to go long-term if the patient can, because it goes deep.
Yeah, I firmly agree with everything you're saying. I want to do a few other things, bigger pieces, but before we get there, I want to ask about this idea of twofold, two perspectives here. So I'll ask the first one first. What is it that you feel most therapists, I'll use that term loosely, kind of get wrong about psychodynamic therapy? And what do you think that they do best if they're using that type of therapy?
Um, I think what they get wrong is the name psychoanalysis has been used for a body of knowledge. It's also been used for a particular type of therapy where you ask someone to lie on the couch and free associate and come 3, 4, or 5 times a week.
Mm-hmm.
That's a very expensive kind of therapy. Most of us can't do much of it. I love to do that kind of therapy, but it is expensive, and I didn't want to spend my career treating the rich, so I only do a little bit of that.
Right.
And so they're mixing up the term psychoanalysis with that particular style of therapy, and that's not useful to them in their clinic and their short-term agencies and their hospital. But what they may not know is there's 100 years of clinical observation and empirical research that has gone into psychoanalytic understanding of people, especially understanding of differences in personality. So I think they get it wrong to think of it as a technique and to think that the technique is that on the couch reassociating therapist says very little kind of technique, because there are plenty of psychoanalytic therapies where it's once a week, or where the therapist is very conversational, where you focus in on things, where you might give advice. They have a stereotype of how analysts practice based on the idea of that one stereotype of classical psychoanalysis. So that was the first part of the question, and I've already forgotten the second part.
It's all right. So what do you think does for folks that are in the psychoanalytic tradition, what do you think that they do best? I would say, you mentioned it there. I'm curious if you would see the primacy of that as well, which is, to me, it's the therapeutic relationship and alliance that you have with the client. That to me, how do I say this? I think there's that's a transferable thing across all therapies, in theory, if you're doing it well. But I think there's something. I think it ties to history and conceptualization, but I think that with those that use the psychoanalytic tradition, there's such a powerful, in a good way, role of the therapeutic relationship. That's what I see as best. But I don't know if you see it the same, or you see something else that they do best.
No, I think their focus on the relationship is profoundly important. I'm not sure it's the best, but it's certainly at the hallmark of the way I think about it. And it's not just the idea that if you're a nice person, you'll set a nice tone and the patient will cooperate with you. It's more that you expect all the feelings that the person has from their history to come into the treatment. So if you're my patient, for example, I like it if you seem compliant with what we're doing. But as soon as I sense that you are unhappy or irritated, I'm going to ask you, how are you feeling now? Does it have anything to do with your feelings toward me? Are you perhaps impatient that you wish this could help you faster? And you want to make space for the negative feelings as well. You want to admit mistakes and repair things that you got wrong. And so the whole part of psychoanalysis that I think is still insufficiently developed in the other therapies is dealing with the negative affects that come right into the work. If a patient isn't getting better, we want to explore what's in the way, not just consign them to, well, they weren't a good candidate for this kind of therapy.
Yeah. So you don't have to pull out, citations here, but I guess just give us the brief, you can pull out big kind of themes here. One of the things I think for a while was, well, CBT is evidence-based. It's evidence-based treatment. They do this double-blind, randomized control. It's been replicated, et cetera, et cetera, et cetera, et cetera. And That's all great. I mean, I think that's all wonderful. I'm very supportive of that. But interpersonal or relational psychotherapy, which is a kind of, I would say, within the world closely aligned with psychoanalytic tradition, is also strongly evidence-based. I mean,
Mhm.
when people make that charge of like, yeah, well, this is just a bunch of, Freud's old theories that people just kind of passed down, and some people maybe retooled it, but we have other better evidence-based treatments. How do you usually respond on the empirical side? Because that's important, right? You want to be giving somebody empirically supported treatment. You don't want to be giving them something that's just a couple of ideas. So what do you when you get that question or that criticism, I guess, what's usually, I guess, the answer you kind of give, or kind of big kind of themes that you can point to of like it is, and here's some things we've known or learned from various studies over the past 40, 50 years.
Well, I say probably many things depending upon what the misconception is that I feel like I'm up against. It's true that psychoanalysis did not originally have a good evidence base for its style of treatment. That is changing very fast, but it was true for a long time. But we did have a vast empirical literature on things like personality differences,
Mm,
temperament,
mm,
trauma, neuroscience, uh, relationships,
mm,
the study of social interaction. We had a huge empirical literature on that.
mm,
And those things I find more valuable in therapy than learning a particular technique.
mm,
One of the problems, and this is not to subtract from the fact that I admire the CBT people for insisting that
yeah.
there be an evidence base for what they do. I think they've had a positive effect on all of us for insisting that. But if you want to study, let's say, obsessive compulsive disorder, if you're a researcher, you have to study a clean version of that. So
Right.
you eliminate people who have comorbidities.
Hmm. Hmm.
Um, so what that ends up doing is it ends up selecting for people who are the healthiest
Hmm.
among that group. People who come in and they say, I have OCD, I don't have anything else, no substance use problems, no personality problems, no trauma. That's going to be your healthiest version. And so you develop a an evidence-based treatment, like let's say exposure therapy,
Hmm.
and it helps the people in your we would say cherry-picked group,
Hmm.
and their symptoms will diminish, and that's all to the good. I send people to CBT colleagues for exposure
Yeah,
therapy.
me too. Me too. Yeah.
However, if you try to do that prematurely with people whose OCD is all involved with other problems, who are more on the borderline or psychotic end of the spectrum of OCD, who if you start questioning their OCD, start treating you as if you're a persecutor. Because, like one of my patients who told me she was late because it just took her longer to boil all her sheets and towels. And I said, you boil all your sheets and towels? And she suddenly, she'd been working with me for 5 years. She suddenly looked at me as if I was a contaminatory
Mm,
kind of person
mm,
and said, of course I do. Haven't you heard about germs? What mother wouldn't boil all her sheets and towels every morning? And she really looked frightened that maybe she'd
mm,
been spending all this time with somebody who was going to
mm,
corrupt her.
mm.
That kind of OCD, you're not going to handle with exposure therapy. And that's where you need another
Mhm,
way of thinking about it.
mhm,
Um, it. So there are limits to the kinds of research that is possible to find evidence-based
mhm.
treatments. And it's very rare in my practice that somebody comes in with one DSM disorder, not comorbid with anything else.
Right. Exactly. I mean, yes, it's the same for me, and I think most clinicians would say the same thing. You don't get this kind of sanitized, pure, if you will, kind of textbook kind of disorder And I understand the scientific method in trying to find the efficacy of a certain treatment. I mean, I understand it, but you're right. There is a kind of whole swath of people that don't fit into that. There is a lot of comorbidities, and it's like, well, what do we do with that? How do we? And I think you need a certain type of a framework. So this is what I want to get to next. So let's talk about conceptualization. That's what a lot of your work is, and that's something that was really helpful for me and many other trainees. So there's a few things I hopefully we can get to after we talk about conceptualization, but one of them is about kind of on the client side. Many clients will come to me and say, okay, I want the tools and the techniques. Tell me what I need to do. How do I fix this? As if it's like a manual or a cookbook.
Yeah.
I get that a lot. And then on the student trainee side, it's very much like, okay, well, what do I do? Like, how do I do this?
Yeah.
What's it, and many of those things are very, respectable. I mean, I think you can understand maybe the intention there, but one of the things is conceptualization. So this is something that when I was in training, and I'm sure many other psychologists will feel this way, and in many ways is this idea of, more so than the techniques or the tools, I think it's more of, how do I understand at a psychological level? How do I understand the human psyche, the human personality? How do I conceptualize? The way I describe it is, I can have a bookshelf, which is a frame. And then I can put all of these different books on there, which would be techniques or tools. But how do I have a frame of understanding or holding what a client gives me, right? They're giving me all of their trauma, their personality things, their temperament, many relationships, views about themselves. There's all of those things. And techniques are very symptom focused, which is fine, but that's the top layer. There's many, many layers to a human being. So I find, and so in this way is, some people will do this in a kind of integrative approach, where you can conceptualize people. How you conceptualize is how you conceptualize a person. If you want to use a psychoanalytic framework, but you could use other techniques from other places if you really wanted to.
Sure.
Many people will make this distinction between intervention, clinical intervention, and conceptualization.
Yeah.
And my as someone that has supervised and someone that is taught now and all these things, is so many clinicians, unfortunately, for various reasons maybe, go into a room with a client and they have no way of conceptualizing a human being. And
we don't teach case formulation anymore.
And that's very, very detrimental, because that's the things that you need when you run out of tools, when you run out of things in the workbook. And some of that has its place. I don't want to seem like I'm totally bemoaning all these things. They're their place, but you need to know how you conceptualize a person has to inform and guide which techniques you may or may not use, instead of treating it like you're throwing spaghetti at the wall and seeing what sticks, right?
Yeah.
So I'm building you up here to kind of say why this is important. So could you explain why we need conceptualization and why that's important, aside from techniques and kind of the interplay with that?
Well, you can hurt people if you insist that your bag of stuff is more important than listening to them and understanding them. And most of us, if we go to a therapist, even if we've been trained that, we should be expecting workbooks and skill training and all that, we want them to understand us. We want to tell our story. And I usually say, when a person puts that kind of pressure on me, well, first let me hear what it's like to be you. I don't know yet what to prescribe for you. So would you mind? I'd like to take a history from you, get a sense of the context of this kind of problem, because people will come in and they'll say that they are or they have something from the DSM, and it may turn out to be something completely different. Like people don't come in anymore and say, I'm a shy person and I want some help learning how to relate better to people. They say, I have
I
social
have this,
phobia.
right. This is my disorder. Let me tell you what it is.
Disorder. The drug companies love this disorder language because they
Yes.
can market drugs for them. And
Right. Right.
to some extent, we've been drinking that Kool-Aid because, to prove that psychotherapy worked as well as drugs, we had to accept the sort of position of the drug companies that
Mhm.
psychotherapy is about applying a fix to a DSM disorder.
Mhm.
But that isn't really what most people come for. They come, they're suffering, they don't understand why. They're anxious all the time, or they're depressed all the time, or they're developing a substance use disorder, or they're developing an eating disorder, or something's wrong. Sometimes it's not in the DSM at all. Sometimes, they're a gay person who grew up in a fundamentalist family who wants someone to bear witness to the fact that they've got to come out to their family and they're scared to death.
Mm.
That's not a disorder. That's
Mhm.
just life is hard.
Yeah.
And you need, a companion in the journey.
Mhm.
So in the psychoanalytic literature, we have language for different ways that people can organize their personality.
Mhm.
You might be more obsessive compulsive, you might be more paranoid, you might be more narcissistic, and so on. But also, at what level of organization
Mhm.
are you? Because let's take somebody like what I said about the obsessive compulsive person. There's a huge difference between the patient who comes in and says, I'm developing these rituals and I know they're crazy. And they started when I lost my grandfather.
Mm.
I just need to find some help with this because I keep feeling anxious if I don't do the rituals.
Mm.
That's a person who's already treating you like a potential helper.
Mhm.
You can see that their problem came on at a certain point under a certain kind of stress,
Mm.
that they see that it is a problem. And then you get a person with exactly the same symptoms, meeting exactly the same DSM criteria, uh, who you find out 2 years into treatment is doing all these rituals.
Mm.
And you inquire about it, and they say, well, that's what my parents did. They taught me to do that. There's nothing wrong with that. How do you keep the witches away if you don't do that? Um, and they and if you try to raise questions about it, they look like you have three heads. That kind of person may have exactly the same DSM diagnosis, but they're going to take a lot longer even to see that they've been constricting their life because of their rituals.
Mhm.
So with eating disorders, same thing. One person comes to a college counseling center saying, I think I'm starting to restrict my food and I found myself wanting to vomit and I'm developing an eating disorder consequence of gaining 10 pounds in my freshman year. This person is likely to be helpable very fast through any kind of therapy.
Mhm. Mhm.
And another person may meet exactly the same DSM criteria in terms of their behavior, but you find out that they've been restricting since the age of 6,
Mm.
that their parents taught them to do that, that they believe that they're overweight, even though they're 87 pounds and essentially dying of starvation. That's a kind of psychotic level of
Mhm.
they will fight you if you try to get them to eat.
Mhm.
That's a whole different thing. They don't see that they have a problem. They were probably brought to the counseling center kicking and screaming by their classmates because they've heard them puking in the bathroom. So it's not even their own voluntary effort to come to you. Those things matter a lot in
Yeah.
terms
Yeah.
of planning treatment.
Mhm.
And it matters. Take a symptom like perfectionism. It matters whether this is a perfectionism of, let's say, a more obsessive compulsive type, where the person is trying to be morally without flaw,
Mhm.
or a more hysterical type, where the person wants to be the best little person they can be, so that they won't be rejected and talked down to,
Mm-hmm.
or whether it's a more narcissistic kind of perfectionism, which is not about trying to be morally as good as possible. It's about looking perfect to other people. Those are three different states of mind,
Mm-hmm.
and they're all describable by this symptomatic term.
Yep.
If you don't know the difference, how are you helping the person?
Yeah, I totally agree. I mean, again, I learned a long time ago. As much as I love differential, it's such a fun thing to do. It's a kind of an academic thing, and I teach diagnosis to grad students, and I love it. I love diagnosis. I think it's a lot of fun. But in terms of treatment, I don't really think in terms of diagnosis, in terms of DSM diagnosis.
Right.
I don't think that way. I think
I don't
more
either.
I think more. I mean, I know them obviously, and I can teach them, and I enjoy an aspect of it. But it's a for me, therapeutically, is trying to understand what are the symptoms that this person has, regardless of their disorder or not, and how is it impacting them. So you gave a really nice way of explaining that, so we can kind of navigate through some of this, a little bit, which is what you were talking about is this kind of level of personality organization. So in the book, and I don't think you're the only one that said this, but there's
No, this is actually Otto Kernberg's great contribution.
Yeah, so you have neurotics, borderline psychotic, and you can explain those terms are slightly dated a bit, but what those mean and what we look for there. So we look for a person's reality testing, how their sense of identity, their object representation, self-observation, impulse control, etc. So maybe just kind of explain those and what we're looking for, because that's really how you're conceptualizing. When somebody, if for a listener, if they go into an office and they go into a therapy office for someone that is psychoanalytically minded, this is sort of kind of what's important of how someone's trying to understand who you are as a person. Like, how is it that you're functioning? How is it that you as a person are functioning in the world, with yourself? So maybe just kind of give what those are and what's being looked at.
Well, when psychoanalysis started, there were just two categories. You're either neurotic or you're psychotic. And if you're neurotic, you see that you're crazy. And if you're psychotic, you don't. You've left the consensual reality of other people. And they thought that the neurotic conditions were the obsessive and compulsive conditions, phobias, non-psychotic depressions, and what they were then calling the hysterical conditions. The psychotic conditions were the schizophrenias and psychotic versions of what we now call bipolar. Over time, we began seeing that it's not so simple. It's not that you're either sane or you're crazy. There was a whole group of patients in the middle, which is where the term borderline originally came from. They're on the border between neurotic and psychotic. They're more intense. They have a lot of trouble with regulating their emotions. They tend to think in all good or all bad terms. They don't have identity integration. When they describe other people, they describe them as all good or all bad, or kind of as monsters or saints, or just kind of impressionistically. Like a patient of mine, I said, "What's your father like?" "Well, he's just my dad." Where there are, so in a good interview, at the neurotic level, we still use that term in the psychoanalytic field for people who can see that they have a problem. It's ego alien. They make a good relationship with you. It's like you're two people looking at the problem part of them. They are able to reflect on themselves. They're able to mentalize other people, meaning they have what philosophers call theory of mind. That like, if you say something that hurts my feelings, if I have theory of mind, I think, gee, I wonder what happened to him that made him say something insensitive. If I don't have it, I think you tried to hurt me.
Right.
Okay. So, and reality testing in general, there are some patients, they've never had a psychotic break. They've never been diagnosable as schizophrenic or manic depressive psychosis, but they mix up inside and outside a lot. They believe their projections. In therapy, they tend to believe they know your mind better than you do.
Mhm.
They are very self-referential. They have annihilation anxiety, not just separation anxiety. They often feel like they don't have a self, not like they have a good or a bad self
Mhm.
state. They don't have a self. So there's a whole continuum from healthy through neurotic through the border, which, and I'm using this in Kernberg's term as a level of organization, not the DSM
Yeah.
type of personality, which is, I think it was a shame that they did that.
Mhm.
But and the psychotic level, I'm not using it as equivalent to being schizophrenic. I'm talking about difficulty really with even feeling like you're alive sometimes,
Mhm.
being terrified of not going on being. Um, for example, I had a patient, he was a pretty high functioning guy, but he said he had a significant paranoid streak. And I thought, okay, he can see it. He's probably pretty healthy. But very early in the treatment, I noticed that when he was talking to me about things that were painful, he would abruptly change the subject.
Mm.
And I called that to his attention. I said, I think I'm seeing a pattern here where when you start to feel sad, you change the subject. He said, oh, yeah, I know I do that. And I said, what's your understanding of what's going on when you do that? And I think I expected him to say something like, I don't want to start crying, or I'm not ready to go there yet. But what he said was, well, I can see I'm hurting you.
Mm.
Okay. So underneath the competence that he had was this conviction that his first job was to keep me okay. And he knew my mind better than I did. And he didn't have the concept of a person who could have sadness on her face as a separate person compassionately toward him. He felt he was damaging me. And I construed that as somebody organized with some psychotic level stuff. So it makes a huge difference for patients where you see them as being. If they're in the neurotic level, psychoanalysis was originally attacked because it was most helpful with the healthiest people. But that's not specific to psychoanalysis. If you're a healthy person and you're in CBT therapy, you're going to do your homework. You're going to cooperate. You're going to find it helpful. If you're in humanistic therapy, it's going to be helpful to you right away. If you're in systems therapy, family therapy, you're going to be working on your family system. So that's not specific to psychoanalysis, but I think psychoanalysis has a longer history than the other newer approaches of looking at what are the implications for if you're in the borderline where you're a very intense person, where you're terrified when you're close to people because you're afraid you're going to be engulfed, but when you're separate from them, you feel abandonment, distress, where your intensity gets you into trouble, where you don't feel like you can describe yourself as both bad and good and other people as both bad and good. And you're either in one self state or the other. And you use very primitive defenses like splitting, projective identification, denial, withdrawal, primitive forms of dissociation, idealization, devaluation, acting out, somatization. Those are among the omnipotent control, among the more primitive ways of being in the world. And if you don't have more mature ways like sublimation or a sense of humor or the capacity to intellectualize about something, if you don't have those, chances are we think of you as needing work on that stuff. If you're in the more psychotic range, you're going to need a very active psychotherapy, very conversational, very supportive, very focused on things that make sense to the person, where the therapist is always paying attention to, are you feeling safe with me or not? So those are some of the implications of where you see people. Interestingly, there is empirical research now. I'm thinking of Carla Sharp's work that's supported this idea that it's more important to understand the the level of organization of a patient than it is to understand what type of personality they have.
Mm-hmm. Yeah, and I think it's more instructive because you're trying to understand. I mean, to me, that's really what therapy is. It's just trying to have
Yeah.
somebody work with you to understand things about yourself, to have a healthier sense of self. Um, I wanted to ask you also, you mentioned it there, defenses. So we have these these two headings, these primitive and mature.
Mm-hmm.
Defenses are mostly or almost all unconscious, right? And so and obviously they can rise to consciousness. So in Freud's topographic model, you have the unconscious, preconscious, conscious, right? And this is something, as you mentioned in the beginning, we still, I think that's in terms of aspects of his thought, that is one of the most enduring aspects. And you see this still today, whether people call it something different or whatever. I had a conversation with Paul Bloom, who's a research psychologist, and he writes some really awesome books, and he's a lovely, wonderful man. And he's super great thinker. And he wrote a book recently, which is based off his intro to psych course at I believe it was Yale, called Psych, and he basically just does a really nice kind of overview of psychology. It's a popular kind of science book, and obviously you got to talk about Freud if you're going to talk about psychology. And he gives him his due. He's coming at it from a non. Right. He's coming at it from a non-clinical perspective. So he says there's a lot to pick on Freud about, and many things, but even he was able to say, you know what, Freud's aspect of talking about sexuality in ways that need to be discussed and how they're connected with things is tremendous. And this also tomographical model of things beneath and things above, if you will, conscious, unconscious, however you want to describe it, implicit, explicit, certain ways of talking about it. And so defenses are part of it. And so defenses are trying to this aspect of the ego, right? Trying to keep things in check. How do and so people don't really know it, I guess, when it's happening. But there's some interesting ones, obviously. You listen, projection identification, reaction formation is super interesting. There's different ways in which people will do this based on where their level of personality organization is. So maybe we just talk generally about defenses, and then we can get to transference.
Well, defenses are universal, and we all can't be overwhelmed by stimuli and by anxiety all the time.
Right.
So, when we're infants, we first defend by splitting. Oh, that's the bad stuff out there. I'm the good stuff in here. Or by withdrawal, for example. I'm overstimulated. I'll go to sleep. Or this is not happening. It's denial. I mean, we all use all these defenses, and they're adaptive. And you tend to develop ways of coping that fit your family of origin. If dissociation is adaptive to your family of origin because your father rapes you every night and then you have to have dinner with him afterward and pretend like nothing happened, dissociation becomes a very organizing defense for you. If you're brought up in a family where everybody's always evaluating everything, you're going to end up with idealization and devaluation defenses because you'll learn that from your parents. Our particular childhood setting, we develop the defensive patterns that adapt to that setting. They may be very adaptive to later life, or they may be maladaptive. When people come to us, it's because their defenses have been maladaptive outside the world of their family of origin.
And I find that people have two responses usually to it. If you kind of catch them on the defenses, because again, there's unconscious elements, so it's like they're not noticing it. There's either another, yes, well, that's what it is. Okay, that makes sense. Or it's the resistance, right? Where it's like, no, that's not what it is. No. I don't need you to analyze me about this. Like, that's not what it is. No, I just felt that way. Or it's like, yeah, but you don't see. They're again. There's again to that personality organization. I usually get one or the other, not to make it this dichotomy, but I usually get a kind of like almost wanting to be like, yes, that's what it is. Or a kind of like, no, that's not what it is. Don't tell me that's how it is. I usually get one or the other typically.
Uh-huh. Yeah, that's kind of familiar. It's all a matter of timing. And if you are right in what there are a couple of possibilities. If you're wrong and the patient tells you that's not what it is, that's the patient is
Then
just
that's on me then.
differing with you. But if you're right, and you time it really well, they'll probably have the first reaction. And if you're premature or unempathic in how you tell them, they're going to have the second reaction. And we all resist change. There's a misunderstanding of the term resistance in psychoanalysis. All systems resist change. I mean, we all cling to what's been familiar, and it's not resistance is not when the patient doesn't want to see what you see. It's the patient is anxious about trying out new behavior or thinking in new ways, because we all are. And that's why they need a relationship within which to try this all out.
Yeah.
Because we resist change.
Talk about, I mean, you mentioned it earlier, and I'm actually really curious about your thoughts here on this, is transference and countertransference. You can describe them what they are. But for a while, countertransference was seen as a taboo, if you will, right? It was the thing that you didn't want to do. And since then, over the past, 30, 40 years, or, we've really learned that we need to use it and use it, very well. And of course, you can use it in negative ways as well. I guess more recently, I mean, I haven't kept up on all the papers on it, but what do you think for yourself, and I guess more generally of how we have a long tradition of understanding and things we don't still understand, but transference and countertransference, and how we use it or interact with it, especially in a I guess a clinical setting.
Well, I think starting with the work of Heinrich Rocker in the 60s, a South American psychoanalyst, we've slowly depathologized countertransference. If you work with only healthy patients, your countertransference is not going to be very strong because they're cooperative, et cetera. But most people that we work with, they evoke feelings from us, and instead of, you can waste a lot of time saying, there's something wrong with you, Nancy. You've lost your empathy. If you're feeling irritated at this patient, what's the matter with you? Go back and think about your own history and your own analysis and see if you can get better. That's just a dead end. But if I can think, wow, I'm finding myself irritated. That's interesting. What's that telling me? Am I feeling what the patient feels? Because Rocker said you're either feeling something the patient often feels, or you're feeling ways that people in the patient's world have felt toward the patient. The first is a concordant, and the second is a complementary kind of countertransference. So once you realize that whatever you're feeling may be telling you something about what's going on with the patient, it makes some patients much easier to work with, because some people don't communicate on channel 1 all the time, which is verbal explication. They communicate through facial affect, body language, and evoking countertransference in you. So I think the relational movement has been very important in continuing the process of depathologizing countertransference, to the extent that relational therapists will sometimes share their countertransference. I find myself feeling oddly bored, and you're not a boring person. What do you think might be going on between us? That there's this sort of odd, it's odd because I'm having trouble keeping my thoughts in a straight line, and that doesn't usually happen to me. Does that happen to you? Are you feeling the same way? Or do other people report that they have that reaction? I don't do a whole lot of that because I think it often is very distressing to patients to find out that they're having that reaction to you. But I do observe it all the time. Wow, I'm finding I'm having the fantasy of adopting this person, taking her home, putting her up in my house, reparenting her. What's going on between us that I'm feeling this rescue fantasy? It's not always negative.
Yeah, I use that kind of with the client, but it depends on the client, depends on how long, depends on what point. It's
Yeah,
usually later in treatment.
yeah, yeah.
Because if you're right, kind of what you're saying about with the earlier point about defenses, if you do it too soon, it can be very disarming, and it really depends on the client, and then the timing of it. I find I have a three final questions here. So the first is, I mean, this is, we could spend hours talking about this, but how how do we train future psychodynamic and analytic clinicians and therapists well, where we don't lose the importance of conceptualization, understanding patients and humans, and all of the things we've been talking about? How do we? Some of that is lost.
Mhm.
Obviously, there's internal battles within the analytic tradition, as there always have been and always will
Yeah.
be. But how do we? I really feel for trainees and students. I want them to get the best and not get anything less than that. How do you feel? In the 21st century, how do we maintain this tradition in the best ways, I guess, to continue to training folks in this way?
Well, I think analytic teachers have to first teach it. Secondly, they have to embody it. You have to talk to your students about how you work, what you said in this situation. You have to show them how useful it is to think in these terms. Once they get that, I mean, I get a lot of people who've been trained in all these different techniques, and they come to me and they say, but nobody ever gave me the structure within which to choose what to use when. And I think there's something about
Mm,
psychoanalysis that thinks about the bigger picture, and they find it very valuable for me to talk about my own experience. The third thing is that people should get their own therapy. I don't
absolutely.
know how you do therapy.
I don't either.
You haven't experienced it yourself. I
Fully
mean,
agree with you.
only to know what it feels like to be in the patient's chair.
Hmm.
Um, not to mention, there's so much that you can learn about yourself that will
Hmm.
help you not
Hmm.
make certain mistakes with patients. But
Hmm.
how do you ever get the conviction
Yeah,
this really helps?
yeah, yeah.
Because your professor told you it does, but you
Right.
don't see it with your patients. You
I
have to find
fully
it
agree.
yourself.
Fully, fully agree. I mean, I know it was required in some courses long or programs long ago, and it's not anymore.
Mhm.
The requirement, maybe some places, it still is, but most places it isn't. And I mean, I think it should be. I mean, I've had my own therapy at various points in my life and for years, and
Yeah, me too.
I've done a type of contemporary analysis where the free lay down, free associate, not 4 times a week, but once a week, but that was the method we use. And I don't I don't I don't I don't know if I could. uh, if you would have asked me this 10, 15 years ago, I would have said, of course I can, but I'm saying it now. I don't know how I could do treatment if I hadn't had my own treatment. I
I
just I
agree.
can't imagine. I can't visualize. I can't picture it. It's foreign to me. So
Yeah, I
I
draw
I
on my own treatment every single day.
I try and really impress upon that for students. The other thing is on the client side. So for many people maybe listening, you know, you don't have to give the sales pitch here, but what would you say, or what would you to the average person that's they feel stuck, or they feel they have some issues, some challenges in their life with themselves or their relationships or things that happen to them. What would you say to the average person that feels that way, to say, you know, you hear a lot of things, and you hear about the exposure and the EMDR and the trauma informed this and the CBT and all those things are great. What would you say to say, maybe you give some of the analytic tradition a glance. Take a look at what they're doing over there. If it's someone pretty worthwhile, what would you say would be the reasoning for getting someone to get in with a person with the analytic tradition?
Well, usually when patients come for help, they're not thinking about these differentiations among people in the discipline.
Yeah.
And when I refer people, I say, I know this person, I know their work. I tend to find out from the patient. I will say something like, look, the research shows that the most important thing is the chemistry between you and the therapist. The personality of the therapist matters a lot more than what particular techniques they're trained in, because you can.
Certainly.
So tell me about what kind of person you think you'd be comfortable with. Do you have any preferences for their age, for their gender, for their sexual orientation, for their background, for their politics? I want to maximize the possibility that you're going to feel like you can really explore yourself with this person. And I listen and I take a lot of time with it. And then I give them 2 or 3 names that seem to fit with what they've said. And they're not thinking about the theoretical orientation of these people. They're thinking, Nancy listened to me enough that she thought of people that might be a good match with me.
Yeah, so I think that's super important. I know that some people have come up to me and they'll say, I went on Psychology today, and there's a lot of stuff on there. I don't know what all of family systems, CBT, like what is all of this? What is all? How do I? And I do something similar. I usually say, look, therapy is. I mean, analogies have a certain half-life, I guess. But I'll say, look, if you're convinced that you really want to do the work and this is a good moment to do therapy, which I think is great, it's like trying on a pair of shoes, right? You go into a store and you got to wear shoes. You got to come out with something, right? But the first one you pull off the shelf and you kind of have an idea of your size. Okay, I'm an 8.5, I'm a 9, I'm a 12, whatever it is. You try it on and it doesn't quite fit. Like you could kind of make it there, but it's not quite there. So you try 2 or 3 other ones until you find the one. They're all okay. They're all shoes that you could wear, but you find the one that fits. Like you got a wide foot or maybe a long foot, whatever, right? I said that's kind of how therapy is, right? They all have their place, and obviously there's some not so good therapists out there, of course, but you got to find the one that you have the fit, and a lot of that comes with the person who it is. It's not necessarily about the orientation. Of course, you want people that are competent and ethical, of course. But you got to find the fit. I usually give some. I get information and I get something like that. Yeah, go ahead, steal it. Yeah, I find something like that. And they, you know what? Yeah, and I try to give them hope because of course, in the current world, it's insurance and a schedule and setting up the initial, and it's a lot of work. And I say, don't get discouraged. I know it's discouraging. You're going to find it and it doesn't work with the insurance or the scheduling, or it's not the right fit. Keep trying. You got to find the right fit and you'll get there. So I try to just, tell them beforehand. It's kind of getting in there is the hardest thing. The last question here. So just a kind of general question is, what do you think, in 20, 50 years, what's the future of kind of psychoanalytic kinds of therapy? Where do you see it going? If you give me your crystal ball, where do you see things going, I guess?
Yeah, I'm not very good as a prognosticator. I know we'll survive because we help people, and they tell people about their experience, and they encourage people to come to psychoanalytic therapists. And we have a lot to offer, and biological psychiatry is running into some of its limits now. People are seeking relationship and understanding. I don't know what psychoanalytic therapy will be most interested in, but it'll depend on what the culture is dealing with most. I mean, contemporarily, psychoanalysts are writing about culture, ethnicity, immigration, trauma, the transgenerational transmission of trauma, how you help people who are migrants, who are oppressed, who are indigenous people. There's a huge literature on psychoanalysis and race, there used to be almost none. It was as if your middle class white heterosexual guy was the standard, and then everything else was a deviation. That's gone out the window. The last meeting of the Division of Psychoanalysis of the American Psychological Association was full of brown faces and young faces and Asian faces. So it's going to pick up the issues that are central to the decades in front of us. We're already developing a small literature on what they call solastalgia, the feeling that the environment is disappearing on us. The earth, we're losing the earth. Our Mother Earth is in terrible trouble. There's a catastrophe ahead, and there's this nostalgia for feeling connected with the planet that people are writing about. So I think the topics will change, but the interest in the unconscious impact and the concern to develop a style of relationship that makes people able to talk about these things and problem solve, and that puts the emphasis on their finding their way to their own sense of agency rather than the expert telling them what to do. That's going to outlast us all.
Yeah, no, I definitely agree. I sometimes I get the question, is AI going to replace us? And I say, no, I don't think so. I don't. We need a human being, and we need a human being to talk to another human being about our most difficult challenges, I think. And I agree with you. I think that they will always be around, and it will always be useful, I think. And the topics might change a bit, but I think the construct there is going to be there. What do I say, Nancy? I mean, this was such an honor and a privilege. I'm so grateful for you giving me your time and explaining all these things, and I'm really proud of our conversation. So I can't say enough thanks to you for giving me your time.
You're very welcome. I enjoyed it myself. I love to spout off on these topics.
I love it too. It's great. Well, big thanks. I appreciate it.
You're very welcome.